everyone, good evening. I do hope you had a nice day and are ready to find out a little bit more on yet another topic, as we do have a special guest once more. This is Dr. Arianna D'Angelo. It's good to have you here with us. And how are you feeling tonight?
Very well, thank you. You?
I am very good and I'm very excited to see and hear what you have prepared for us. It's going to be definitely interesting. And before we start with your presentation, I just want to mention, as always, that as you know, we are here every single day from Monday to Friday to support you. And I'm sure you also have some questions here tonight. So, as always, remember to type those in the chat section, and Dr. Ariana will be able to answer them for you right after the presentation is done. And as you know, we are here because we simply want to help you out a bit, answer your questions, but also give you the opportunity to meet top fertility experts like Dr. Ariana is here with us tonight to help you out a bit as well. And as always, I want to mention that this is all possible, all those events that we have prepared and are still preparing for you, simply because it wouldn't be possible without the help of our ambassadors and partners. So, as always, thanks a lot for your constant support. And well, tonight's topic is definitely interesting, and it is about the what to expect during an ultrasound, egg collection, embryo transfer. So we will, as I mentioned, start with Dr. Ariana's presentation, and let me just mention that she is the consultant assisted production at Wales Fertility Institute. So thank you so much for accepting that invitation, and thank you so much for joining us tonight. And well, are you ready to start off with the presentation?
Yes, thank you very much,
Thank you
Caroline,
indeed.
for the lovely introduction and good evening, everyone. And welcome to this webinar this evening. I would obviously like to thank my IVF Answers and IVF Media for giving me this opportunity to meet you virtually and entertain you for the next hour. And I would be very, very happy to take all your questions. So, my presentation is a little bit interactive because I thought that it's very useful for you guys to actually see what we look at when we see you in clinic. So I did put some video clips, and I hope that that will make the presentation a little bit more alive. So starting with the ultrasound scan. So the ultrasound scan is the first step when you start your fertility journey. You see one of us, one like someone like me, a doctor in the clinic, and after we ask you lots of questions about all the sexual life, how many years you've been trying, and we ask you what you eat and what you do during your your life and everything. Then we say to you, oh, now we would like to do an examination, and we show you this basically, which is quite scary, I think, for the patients. This is the ultrasound probe. Again, it's quite an intimidating instrument because it's long and big, and it does go down below. So the actual procedure is quite intimate, and it does require a little bit of preparation. But what is good about the ultrasound, the internal ultrasound scan, is that it is very, very useful for us as a doctor. We always say, in the past we used to do internal examination with our hand, but this is like having the eye on the finger, we say, because we with our hand we can't really see what's going on inside, whereas with the ultrasound scan, with the ultrasound probe, we actually able to see inside the body. And it's very important because then together with you we discover what probably might be the problem, and we can do something about it. So Few things we ask, obviously, before we start with an ultrasound investigation is whether you have any latex allergy, because most of the clinics we use a cover to go over the probe, which is made with latex. Nowadays, for example, in the United Kingdom, we all use latex-free covers and latex-free equipment, but still, it's very important that you tell your doctor if you have a latex or rubber allergy, because that can be quite dangerous. We will apply then some lubricant on top of the probe, and again, that's it's very important. The lubricant is water based. You know, it's just a very liquid and not toxic, because. Let's not forget that after you have the consultation with the doctor, you might want to try conceiving naturally, and if we apply something which is toxic for the sperm, then you're not going to conceive for that reason. So it's very important that the lubricant is also something which is friendly for conception. Then we will ask you to go to the toilet and empty your bladder, because the best way to look at the inside, so the womb and the ovaries, is without with the bladder empty. If the bladder is full, majority of the image will be covered by the bladder, and also will be quite uncomfortable for you. So it's very important that you go to the toilet, empty your bladder. It's very important to give verbal consent for the examination. As I say, the examination is an intimate one, and you want to make sure that you are fully aware of what's going on, and your doctor needs to have your approval before doing anything, even if it is an examination. It's also usually, this happens in the United Kingdom, I'm not sure what in other countries, but it's good practice to have a chaperone with us, someone like a nurse, or a student, you know, someone who can be there also if there is any need. The scan itself is very well tolerated. Even if the probe is this long, actually the thickness of the probe is like a finger, like a tampon, so it's not very big at all. And don't forget, only the probe will go in only for a few centimeters, so it doesn't actually go inside all the way through. This is for the doctor to maneuver the probe, so the actual length is not too bad. So once the technology is set up, then what we are interested in is to look at your internal organs, primarily your reproductive organs. So we want to look at the womb, which is this image here, and I will show you now specifically what we look at inside the womb. And we want to look at the ovaries. You should have two ovaries and one womb, so we can look at the ovaries, at the eggs, and again I will show you in more details what we aim to achieve. So the next one is a video which has been shared with permission from CRC Press. So I thank the publisher to give me the opportunity to share and make this video available to you. And now we can play the video, and I will show you. Now this video, it looks a little bit artificial, and it is artificial. It's actually a video that we use to teach ultrasound to our trainees, and it is based on what is called Scan Trainer. So this is a simulator. So it's like playing with a Wii machine. We have an aptic, and we show the student how to perform an ultrasound scan. So what you see here on the right of the screen is a flag and the inside of the vagina here, and the internal organs. So this is the belly, the tummy, and this is the spine. This is the bowel, so the blood there. And the probe goes inside the vagina, and this is what we actually see inside. So we see the neck of the womb, which is the place where we take the smear test, the pap test. Then we see the womb in its length, so that's the uterus. And when we look at the uterus, we want to make sure that it is nice and regular. So this is the bladder here in black. and the uterus should be regular and normal. So we examine the uterus in many views to make sure that we don't miss any abnormalities. Sometimes people have two uteri. Sometimes people have a uterus which is split in two. Um, or they have a small uterus. So we look at everything in details, and also we look at pathologies like lumps and bumps, like fibroids, polyps, things that can affect, fertility. Then here we look at the endometrial cavity. So this is the endometrium. We see the sonographer here is measuring the thickness of the endometrium. And this endometrium is actually the cavity where the baby develops. So it's very important that the lining of the womb or endometrium is nice and regular. You see here three lines, and those three lines are usually suggestive of an endometrium in the middle of the cycle. So this is usually the picture we get when a woman is fertile. And it's very important that we acquire all this information from the ultrasound scan so that we make sure that the place where the pregnancy is going to develop is actually healthy and ready for the embryo to go back or for the pregnancy to develop. I always tell my patients to think about the uterine cavity as an hotel room. It's the hotel room for the baby. So if there is someone in the hotel room, surely you don't want to share a room with anyone else. That's your room. And that is what we want to make sure. We want to make sure that the hotel room is nice and empty and comfortable. So if there are polyps, fibroids, anything unusual, adhesions, scarring, anything unusual inside that hotel room really needs to be sorted out before we transfer the embryo, because it will make the environment hostile and not comfortable for the pregnancy. So if we proceed then with the next slide, this is now a video of the ovaries. So it's very important that we look at the uterus, but then we want to make sure that we look at the ovaries, because the ovaries are like the bank that contains the eggs. So it's important that we make sure that there are both ovaries there, and those ovaries contain some eggs. So we can see here the bladder. By moving the scan probe inside, you can see the uterus. And by moving the probe up and down, you will see the appearance of the ovaries. So these are two ovaries, the right ovary here and the left ovary here. You will see as well how important it is to see these black areas inside the ovary. Yeah, those little black area. These black areas are called follicles. They are actually called antral follicles, and they contain the eggs. So what we do is we count them. We make sure that you have at least 4 antral follicles each ovaries, and that is considered normal. And some people have less, some people have more. If you have lots of antral follicles, that means that the egg reserve is quite high. If you have less antral follicles, the egg reserve is quite low. And again, these findings are very important for us, but very important for you, because they have consequences on the way we're gonna stimulate your ovaries and on the way we're gonna attempt to get you pregnant. So this is the image of the ovary. As a normal ovary with lots of nice little follicles. And we then measure the ovary, and we make sure that it is healthy and there are no cysts or other signs of pathologies. We also look at the position of the ovary, just to make sure that it's very close to the probe. So we want the ovary to be close to the probe, because eventually we're gonna stimulate this ovary and we're gonna get some eggs out of it. So we don't want ovaries to be all the way up in the belly, because that means that the procedure vaginal is going to be almost impossible, and it's going to be very difficult to collect eggs for the IVF. Yeah, so that's another image of the ovary. Now, the egg reserve is very important, and that brings me to a topic which is quite controversial. Lots of patients ask me how, if they got low egg reserve, how they can get more eggs. The problem is that we are born with a set amount of eggs, and they stay with us all our life. So it's very important that we protect our eggs, because the eggs are not regenerate, they cannot be regenerated. It's not like the sperm that is produced every 3 months, freshly new produced sperm. The eggs stays with us, so it's very important that we look after them all our life. And it is physiological that after a certain age there is a reduction in the egg reserve. So the measurement of the follicles, sorry, the measurements of the ovaries is happening in this slide, and now you will see also the measurement on the other slide. One other thing that we look during the ultrasound scan in this area near the ovaries is the fallopian tubes. The fallopian tubes are not visible normally because they are quite little, tiny. They are only visible if we inject some dye. So there is a possibility to inject some contrast medium and do the ultrasound scan to check whether those tubes are open or blocked. And that is called Hycosi test. If the tubes are damaged and they are swollen, then we will be able to see them on the ultrasound scan, but only if they are damaged. And if they are damaged, unfortunately, they will need to be removed before proceeding any further. So this was just a demonstration of the uterus, the ovaries, the pelvis, with the ultrasound scan. So this is what happens when you have your investigation done, most of the time at the first appointment. However, during the IVF treatment, the ultrasound is used almost every day, because with the IVF treatment, we aim to stimulate those little eggs, those little follicles that I showed you here in the ovary, and we stimulate them with injections. And in order to monitor, to make sure that those little follicles are growing and the egg could be mature and be collected, we need to do an ultrasound scan. So the same procedure that I showed you before, but this time we will look at things differently. We will look specifically at the follicle size, and we will make sure that those follicles are increasing every day, 1.5 millimeters a day, roughly, until they reach a maturation, until they reach a good size. And that is then the time when we aspirate the eggs, which I will show you later in this presentation. Once the eggs are aspirated, we mix them with a sperm in the tube, and then we create a little embryo which can grow in the lab up to day 5, day 6, and then we will be transferring the embryo back to the womb here. Again, that is another procedure that is done under ultrasound guidance, and I will explain that in more details. So going to the stimulation phase, there are different protocols that we can use for stimulation. I'm not going to describe them all because this is not the main topic for this presentation, but I'm happy to answer your questions if you have any later. These are drugs that are usually given subcutaneous, and they can give some side effects like menopause, hot flashes, a headache, tiredness. That's the first part of the downregulation. Then obviously there is the hormonal stimulation, which is when we actually stimulate the egg growth, and that is when people can feel a little bit bloated and generally unwell. And then the third part is the use of the progesterone, which is the pessaries or injections which help the embryo to stick, to implant in the womb, and that can give also some potential side effects like constipation, discharge, feeling bloated. The image that we look at is the ovary here, And we aim to recruit between 5 and 15 follicles during the stimulation phase. And the ultrasound scan, as I said, is used almost daily to monitor how the follicles are growing. And this is the image that we expect then to see during the stimulation phase. You can see the difference between the previous image and this image. This ovary is now quite big. It's almost 2-3 times the normal size, and it contains lots of follicles there. And each of these follicles, we measure them in 2 dimensions, and we take the average of the measurement and we plot it in a grid so that we can monitor how these follicles are growing. And that's very important, because if the follicles don't grow the way we expect them to grow, that will have consequences on the success rate. And sometimes we have to suspend the treatment if we feel that is not going in the right direction. So once we look at that, once the follicles reaches around 18, 19 millimeters, so or 20, that is the time when we expect the egg to be ripe, mature, to be collected. However, because the stimulation is all very much artificial and everything is artificial in our body, we need to prepare for the egg collection in such a way that we need to make sure that the egg complete the maturation before it's actually collected. And that is why we give an injection. We ask you to take an injection which will require around 36 hours to be completely active. And that is the time that the egg needs to complete the maturation. So this final injection is called also trigger shot. And it's very important that the patients stick to the rules in terms of time, because if we retrieve the eggs too early, so if the injection has been taken too late and we go too early, then the risk is that those eggs will be immature. But if you take the injection too early and we go too late, then the risk is that you will ovulate. So it's very important that the timing is right. We say on average 36, but anything between 34 and 38 hours is reasonable to have mature eggs. The egg collection, I will describe it in a minute, will be done, most of the time is done under sedation, strong painkillers, because otherwise it's quite painful. Involves the insertion of the probe that you saw before, so it's the same probe, but this time there is an adapter on the top of the probe, and this adapter is to allow the needle to go through the vagina here inside the ovary. And the needle is inserted only once through the vagina inside the ovary. Once it is in the ovary, then it will go in and out each follicle and taking the eggs out. Once this ovary is done, then we will then proceed, move the probe to the other fornix and go into the right ovary and do the same procedure. The needle is connected to a tube and to a pump, and is the operator usually aspirates the eggs by pushing the pump, and the fluid will go in the tube, which is then checked by the embryologist. So the IVF treatment is a teamwork. So it's important that these are the instructions that we usually give in view of the egg collection. So to be nil by mouth, obviously, so do not eat before, because 6 hours before, because of the anesthetic, and also we advise not to drive or take any legal decision for 24 hours, again for the risk of the because of the use of anesthetic. So I've got a little video clip which has been clearly has been given by CRC press, and this is the video. Now you can see here this dot line is the needle guide, and this is where the needle is inside the follicle. You can see the follicle reducing and disappearing, and that black is actually the follicular fluid which has been sucked out and given to the embryologist. I want to ask Caroline if you can replay the video, because I want to show something which is very important for the patient, which is basically here. Can you see this long line here, which is pulsating as well? So this is a big blood vessel. So that's just to say that the procedure needs to be done in safe hands, because the needle, as you can see, is very close to that big blood vessel. So there are potential risks of doing this procedure if the operator is not fully trained. And it's very important that you are informed about the risks, and which are mainly, potential vascular injuries or bleeding or infection. And these kind of things are very, very rare. I would say the injuries is probably 0.3%, or sorry, 0.03%. This is really, really rare. But the procedure needs to be done by operators who are fully trained and qualified, because it does carry some risks. So the once the eggs are collected, sorry, once the eggs are collected, they, as I say, they are inseminated with the husband or the partner sperm or the donor sperm, and this is what we have most of the time is an embryo. Okay. This is a very beautiful embryo. It's called blastocyst. It's an embryo who's been already cultured for 5 days in the lab, and you can see it's a little bit of it's almost on its own a small pregnancy, because this is the inner cell mass. So this will become actually the actual baby, and this is just some fluid inside the embryo. So what happened then, once we transfer the embryo here, that the embryo will hatch from the membrane, from this thick area, and then implant in the womb. Obviously, that's not always the case, but when the pregnancy is established, that is the case. So how we transfer an embryo inside the womb, we use this funny instrument here, which again is not very comfortable. These are unfortunately things that us women have to go through. And this speculum is the same instrument we use for the smear test or the pap test. So it's not the best. However, the actual procedure is not painful, but it is a bit uncomfortable. And it's usually done without sedation, unless there are some complications or some problems, or unless the patient is really anxious. It can be done with the help of some sedation. So what we do is we position the instrument here inside the vagina. We clean the neck of the womb, remove all the mucus, and then we gently pass a catheter. So it looks like a needle here, but actually it's a catheter. It's a very, very thin straw. And then we inject the embryo inside the womb. So I'll show you the picture on the ultrasound. This procedure is usually done under ultrasound, and this time is with a full bladder, because the ultrasound is done on your belly, so it's actually external. So the bladder here is black, and it works like a window for us. So through the bladder we can actually see what happens inside the womb. So it's very important to have a full bladder for this reason, because then we can see, and you can see as well, but also because the bladder will make the womb straight. You see how straight it is, and that will make the procedure very easy then to perform, because normally the womb will be actually flipped. So it will be when the bladder is empty, the womb is actually flipped either backwards or onwards. But when the bladder is full, the womb is straightened, and when the womb is straight, then it's easier to pass the catheter. So here you can see the neck of the womb, here the cervix. This is the catheter, which goes all the way inside, and then almost 1.5 centimeters below the top of the womb. But that's the right place where to put the embryo. And the embryo We can't see it actually with a naked eye. It's microscopic, it's really tiny. However, the embryo is contained in a drop of culture media, and this culture media with the embryo is visible actually during the ultrasound scan. It looks like this little white dot, and most of the time we are able to see it very well. We take the picture, we take a video as well, and we give this picture to our patients as a memory really, and you know that, and also to as a proof that everything's gone well and the embryo is there. And that is when we say the patient is virtually pregnant, or also called pupo, I think, pregnant unless proven otherwise. And that is the start of the 2 weeks of wait before the pregnancy test take place. So this is the embryo transfer. Just to conclude then with my presentation, I wanted to just to really quickly go through the risks associated with the IVF or ESHRE procedure. So the main risk is the ovarian hyperstimulation syndrome, which is when the ovary here, you hardly recognize the ovary. This is so different to the ovary that I showed you at the beginning, tiny with just a couple of little follicles. So this is a big ovary of the size of an orange with lots of follicles. And this will happen sometimes when some women have an overreaction to the drugs. And unfortunately, this can be quite life-threatening, in fact. It's very important that we identify well in advance who is going to react or overreact, and there are lots of strategies that we can put in place to reduce the risk of hyperstimulation and to make sure that the treatment is safe for the patient. So on the other end, we have the other end of the response, which is no response to the stimulation, also optimal response. And that is, again, very disappointing, because if there are no eggs or very little amount of eggs, then it's very difficult to achieve an embryo of good enough quality to give a pregnancy. Nevertheless, these things still happen. And we always say it's not just quantity, but it's also quality. And sometimes you only need one good one to actually give you twins. So allergic reaction to sedation, to these are potential complications of the egg collection. I went through that. Some injuries to internal organs, very rare but still quite dangerous. Sometimes the egg and the sperm don't like each other. We put them in the dish and they're not interested. The sperm is just spinning around, not interested in the egg. That happens between 3 and 7% of the cases. And it's very disappointing, because after 24 hours we find out that there are no embryos developed. And that is called failed fertilization, which is quite disappointing. And the treatment for that would be ESHRE, which is when we inject the sperm inside. So we actually push the sperm to get in. Sometimes the embryo doesn't like staying in the lab and stops growing. And again, these are all complications that can happen. And it's important that you are told all these things before starting your treatment. Multiple pregnancies. Obviously, still there is a 8-10% chance to have twins, even if we transfer one embryo primarily, but the embryo can divide and give identical twins. And when you transfer 2 embryos, the risk goes up to 30-40%. Miscarriages, 1 in 4 couples unfortunately miscarry on the first pregnancy, and that's nothing to do with the IVF. However, it is still very devastating and very upsetting. And ectopic pregnancy, I showed you a nice picture of an embryo inside the womb, and we, as I said, we take the picture, we take the video clip, we know exactly where we did leave the embryo. But I can tell you, believe me, in almost 20 years of work, I found embryos anywhere, everywhere inside. I found them in the ovaries, in the bowel, in the back of the womb. So these embryos, they go around. And sometimes, unfortunately, they implant in the wrong place. So that is when there is something called ectopic pregnancy, or pregnancy of unknown location, where we don't even know where the pregnancy is because we can't find it. These are obviously abnormal pregnancies, and they can be quite life-threatening again, so it needs to be dealt quickly. I did put as a complication also the COVID-19, because this is something new which we are facing, and we don't know the effect of the virus on the eggs, on the embryos, on the implantation, on the sperm. There's still lots to study, lots of research needs to be done, and I know many of my colleagues are already on board on that, and they are producing preliminary papers reassuring. But the truth is, we don't know much about the virus, and we need to keep monitoring the situation. And you having treatment during this uncertain time, you need to share responsibility with your clinician and with your clinic about the outcome, because again, it's very, very difficult to know what the effect could be of the COVID-19 on pregnancy. And finally, treatment failure is obviously, that happens in majority of the cases, and it is upsetting. But I always said to my patients to think about the constructive side. So let's go through the cycle together and find out if there is anything that we could learn and we could do differently. So it's always important to reflect on the cycle and then try something different. Yeah, so that was my last slide. This is to say to thank you actually for listening. I just wanted to say that I'm very active on all social media channels. So please get in touch, follow me. And this is the book where I took the videos from, and is the book that me and my colleague Professor Amso have released recently. So it's available on Amazon, but it's primarily for students or for specialists. But it's all about ultrasound, which is our passion. So thanks again for listening.
And thank you indeed for a very interesting presentation. Thank you also for those videos, because definitely it was interesting to see how it exactly works. So huge thanks for that, and of course for explaining all those details already. And well, I believe we do see there are some questions ready. But of course, I want to remind everyone that if you have any questions, anything that's on your mind, just go ahead and type those in so that Dr. Arianna can help you out a bit. And Dr. Arianna, are you ready to answer some of the questions?
Yes, looking
You hear
forward to
this
that.
then, okay? Definitely interesting questions that we got so far. So let's have a look at the very first one here. Is better done on day 10 after embryo transfer too early?
Right, good question. It very much depends on the stage of the embryo when you had your embryo transfer. So if you had an embryo transferred on day 5, then the embryo, so the blastocyst stage, then it takes around 48 hours actually for the embryo to implant. So already after 10 days, you will have, if you have a blood test, you will have some evidence of pregnancy. If you had an embryo transferred on day 2, on day 3, then perhaps leave it a couple of days more. With the urine pregnancy test, we suggest to wait 14 to 16 days, but that's really, quite a lot. Because some of the urine tests are not as sensitive to pick up the pregnancy, but the blood test definitely after 10 days will be fine.
All right. And thank you so much for the very first question. And of course, as you see, this is the very small question you have answered just now. And in fact, there is another one, okay? I guess we can go straight to this one. At what week of pregnancy we can identify genetic disorders, birth defects of the baby accurately?
Right. So normally as part of the IVF treatment, we offer an early pregnancy scan, and that is usually a viability scan, just to make sure that the pregnancy is in the right place, is viable, and then and there is a baby's heart. So then after that, usually we refer the patients to the obstetrician, to the department, or to the midwife. There are a series of blood tests and an early screening test that can be done even at 10 weeks of pregnancy, like the CVS, for example, the Corius Valus sampling, um, and the scan usually on the first trimester, so around 10-12 weeks, would identify some problems. But it depends which birth defects we're talking about, because the spectrum is quite broad. In terms of genetic, the best things to do is either have the blood test for the non-invasive genetic test, or associated with the nuchal translucency measurement for the identification of Down syndrome. Um, and then obviously, if you want to have more precise answers, is the CVS between 10 and 12 weeks. Otherwise, wait for the second trimester, but it becomes more invasive for the pregnancy in a way, and for the mother as well, because finding out about this while the pregnancy is advanced can have quite a lot of consequences, emotionally. Um, but yeah, 10 weeks, 10, 12 weeks.
All right. Thank you so much. And sorry, there is a follow-up, okay, from the very same patient. Cut foot, cleft palate, heart
Yeah, okay.
defect.
So these are, yeah, so that's why I was asking which kind of birth defects, because things like the problems with the belly, like herniation and things like that, or hydrocephalus, can be identified at 10-12 weeks. But obviously these kind of defects are a little bit more advanced. So normally there would be an ultrasound scan done at 20 weeks, and that is the anomaly scan, where we look specifically at each organ inside the baby's body, and at the brain, bladder, heart. So some defects can be already we'll find out it at the 20 weeks at the anomaly scan.
Excellent. Thank you so much for the explanation as well, right here. And there is a thank you from the patient for you also. Okay.
Thank you.
Wonderful. Thank you so much indeed. Let's have a look at the next question. For embryo transfer, when you say there can be sedation if there is a problem or patient is anxious, what sort of sedation is given? Example, gas and air, general anesthetic.
Yeah, so the gas and air, we don't tend to use it, simply because we do the embryo transfer very close to the lab, and we don't know if this gas and air is actually toxic for the embryos and eggs. So I don't think it's recommended. And general anesthetic, we don't use it either. For sedation, is usually we give some propofol or morphine. So some strong morphine or a little bit of Valium. So it is called conscious sedation. Basically, the patient is awake and tell the anesthetist if she requires any more painkillers. The whole idea is really to relax the pelvic area. And we find that when the patient is relaxed, actually the only instrumentation that we use, like the speculum, goes in nicely, and it makes the procedure actually easier from a technical point of view as well. So some patients who are anxious, so they tend to contract the pelvic floor muscles, and that is even something that they can't control, then they will definitely benefit from having some conscious sedation. Occasionally, we also prescribe some Valium to take perhaps the night before or the morning of the embryo transfer, just again to relax a little bit before the procedure takes place.
And wonderful again. Thank you so much for yet another question and your thorough answer to it as well. Thanks a lot. All right. Next question is up right here as well. So, what do you see as the future of IVF with so many women looking to start a family later in life? Definitely an interesting question.
Yeah, definitely. Thank you. Thanks for the question. Yeah, so the future is gonna be artificial gametes, which I'm not gonna talk about because I don't really know much. But we hope in future we'll be able to create eggs and sperm in the lab so that we don't need anything else. But that's that's a little bit far. Um, and we just have to be realistic with women, and I think it's very important that two things are very important. One is education. So we have to start educating our young generation that is very important to look after your eggs. So don't smoke, don't drink too much, think about these things, because the eggs stays with us for all our life, and when we reach age 40, 44, the eggs have been there for 44 years, so they obviously are the reflection of what we've been through in our life. If we've been having lots of nights out, lots of drink, lots of smoke, lots of drugs, or unhealthy lifestyle, unhealthy diet, these are all things that day by day actually are seen in the eggs. So that's why it's important to do fertility education, which is something which is happening more and more now, and I'm really really glad to see that happening also in high school alongside with the family planning. The other thing, with the second thing that we can do, is also to start thinking that is things that we see out in the press that they are not always true. So all these celebrities getting pregnant in late 40s, in 50s, having children at any point in life, most of them actually are having egg donation, which is a perfectly acceptable option. And when you don't have eggs, or when the eggs are not of enough good quality, but they don't say. So obviously the message that goes out there is that you can get pregnant anytime in life, at any point. But unfortunately, we are not at the stage that we can have an egg on demand in a way. We need to do some more research. So yeah, so just my message to all women is really just to look after their eggs as much as they can.
And wonderful. Thank you so much for that question, indeed, and of course for your thorough explanation, because it is true. It is something that has to be spoken more about. It has to be educated, and I'm glad that you have also added here this info here. Thank you so much for that. Okay, and let me go straight to the next question. So, how should surrogates be protected during pregnancy with COVID?
Ooh, that's a difficult one. Um, I don't know. I don't know is the answer, because what's happening now as well is that there is the the vaccine. So the recommendation from the Royal College, from the our fertility societies here in the UK, is that if you are if you're pregnant, or if you're gonna get pregnant, so if you're planning to get pregnant, is do not vaccinate. However, we have to say, well, do not vaccinate for 3 months, or if you vaccinate, you can't get pregnant for 3 months. So it's a bit of conflict there, if it is important to get a vaccine, or is important to get pregnant, and that very much depends on the personal circumstances. There are some patients who are a bit sick and they really need the vaccine to protect them, beside the pregnancy. Now, whether surrogate would come into that category, I don't know. There is really no much that we don't really know. There is nothing has been said so far. Um, in our clinic, we have put a series of measures in place to try and protect from COVID. Obviously, starting from the full personal protection equipment, we try as much as we can to do things online, less limit, the footfall in the hospital, and also we are doing some series of swabs, COVID swabs, before the procedure and during the procedure, just to make sure that the patients and the partner are negative. However, the main recommendation would be just to try as much as people can to avoid to catch the virus to start with. So just follow the recommendation from the government on wearing all the masks, hand hygiene, stay safe, basically not mix with other people until at least the pandemic is under control with the vaccine. That this is what we all hope. But as far as I know, there is no special protection in place for treatment. One thing could be perhaps to delay the pregnancy, but it is hard to ask really. So yeah, I don't really know.
And thank you, of course, still. I mean, this is still something that
Mm,
we need to, I guess, wait for some more info. However, thank you so much for this question. This is definitely something that we need to look
very.
out for and just simply wait, I'm afraid. Yeah. Still, thank you so much. Okay, and let's have a look at the next question with some more details. Okay, so do you think it's much to take fish oil only 700 milligrams pill per day, Garden of Life, vaginal care probiotics, 50 billion and 34 multi-strains, only one pill per day, Garden of Life vitamin code prenatal vitamins per day, folate 1000 milligrams, one pill per day. Anything you can advise?
Yeah, that's quite a lot of supplements. I can see that they are all very useful supplements, so I don't think they will be too much or contraindicated. What is definitely evidence based is the folic acid. So the folic acid, it's a must. We all have to advise to our patients to start taking folic acid the moment they want to start conceiving, because that is being proved that does reduce the incidence of spina bifida, so neural tubal defects to the baby. There is also more and more evidence about the vitamin D. So it's very important that with these prenatal vitamins, I believe that means that they all contain all the vitamins that are required in pregnancy, like vitamin B, vitamin D, vitamin C. So iron, the ferrous sulfate of iron is important. Fish oil and probiotic. I'm not really, aware of them, but I think they are all good for for an healthy lifestyle. And if someone is not eating, perhaps if you're vegetarian or or vegan, and you don't get much intake of proteins, then perhaps this is where you need more uh, you know supplements. But yeah, no, I think it's very important to take supplements nowadays. Excellent.
Wonderful. Thank you so much indeed for that advice as well. Okay. Sorry, there is a follow up. Okay. How about vitamin D? Is
Yeah.
1400 milligrams per day? Okay, then.
Yeah, I think that is the recommended dose. I'm not entirely sure. There's been some papers recently published saying that the vitamin D is definitely improving the outcomes. It is very important also for the prevention of COVID. So I would definitely recommend. Also, depending where you live, really, like if you live in the UK, don't see the sun that much, so it's important to have supplementation.
All right. Again, thank you indeed for the clarification to this one. There are like two questions left, so we will be slowly finishing. However, if you have any questions that you haven't yet asked, go ahead and just type it in. And the next question is, do we get better egg quality with 10 days stimulation than more? When do eggs get over mature?
Hmm. Yeah, that's a very, very nice question to ask, actually. Very good. That is, I guess, it depends on the experience of the doctor as well, to to make sure that we go at the right time. And that's one of the challenges of our job, to make sure that we don't go to collect the eggs when it's too early, or when it's too late. Sometimes this is a bit of a learning curve. Each woman is different, each patient is different, and the difference is not just between the patients, but it's also between the same patients in different cycles. So some patients react to a drug in a certain way, and then the same patients react to a different drug or the same drug in a different way. So we have obviously there is a minimum number of days that would be advisable of stimulation, really, and to go too early in the stimulation is not just a problem for the eggs, but it's also a problem with endometrium, because don't forget that those eggs produces hormones, and the hormones will prepare the lining, the endometrium for the pregnancy. So it's very important that there is enough exposure to the endometrium, to the estrogens, to the hormones. Otherwise, we end up having an embryo which goes in an endometrium, an endometrial cavity, or an environment which is not actually on timed with the age of the embryo, and that is one of the reasons why embryos don't implant if the endometrium is not well prepared. So yeah, so there has to be at least the 10 days of stimulation, really, to allow the good maturation of the lining, and then the decision is usually taken together. It's not just the follicular size, but it's also the thickness of the lining and the appearance of the lining. Once we get those eggs out, then we expect some of them to be immature. So not all the eggs are mature. Maybe 15% of the eggs can be immature. Very rarely they are over mature. But sometimes if they are over mature is where maybe we left it too late to collect, and in some protocols this can happen, because they don't get released because you're taking the drugs to stop you from releasing the eggs. Nevertheless, they pass that stage and they're just not good enough to be fertilized. So it's very important. That's part of the experience of the doctor as well, of the clinic.
And amazing. Thank you indeed so much for yet another interesting question and, well, for your thorough answer once more. Okay, next question might be our last one, but of course, I want to remind everyone that if you have any left, you know what to do. And let's have a look at this question. So, what non invasive test can be done for surrogates to make sure baby is healthy and growing well? When should they be done?
Right, yeah. So there is the new non-invasive fetal testing, which usually is done in the first trimester, and is the sampling of the cells in the maternal flow, blood, to see if there is any problem. That can be also associated with standard tests that are done usually around 14-15 weeks. Then, as I said, yeah, obviously there could be other tests, but they are invasive, so we wouldn't recommend. And then a series of scans to check that the baby is growing well, associated with a Doppler study as well of the vascular, so of the cord, just to make sure the baby is actually feeding well as well. Yeah, so this is usually done in the antenatal clinic as part of fetal medicine. I don't do obstetrics, so I don't really have many specific information, but there is definitely a blood test, non-invasive blood test that can be done to find out about genetic abnormalities, and then the series of scans, obviously, all the way through the pregnancy.
All right. Again, thank you indeed so much for that. And actually, there is a follow up. Okay. So let me just go straight to this one. So, what would the doctors look for in these non invasive tests? Embryos have had PGD24.
Yeah. So the embryo had the PGD, yeah, and they so when we do PGD, we usually advise to do some antenatal testing to make sure that the actual PGD was right. So it I think this is what you asking. So yeah, so they will look at the genetic abnormalities like Down syndrome, Turner syndrome, or monosomy. Yeah, anything that can be genetic, just to confirm the PGD, I guess. Is that correct? I'm not sure if I
Yeah, of
understood
course.
the.
Angela, if you just let us know, okay? And we will make sure, of course. Someone is typing, so I believe it is Angela. So
Yeah,
let's
yeah, yeah.
give it a second. And there is like one more questions that is shown right here. Okay, yeah, Angela has added here. Yes, but anything else we should look for?
Um, in the pregnancy, yeah, no, it's usually it's the ultrasound, the Doppler for the fetal well-being, and the genetic testing. I don't think there is anything else. Echocardio, obviously, of the baby, if there are any concerns. And then there are, 3D, 4D ultrasound to look at the face, if there is, any problem with the cleft palate, and that. But that is usually more advanced in pregnancy. Um, no, I think that's, it's enough screening, really.
All right, of course. Understood perfectly. Thank you so much for that one. Okay, next question has shown right here. So I have heard that Paragovaris give very good egg quality. Is the best drug? Is it better than Gonal F for advanced age women?
So Pergover is a bit different. It's the same make as Gonal-F, but the actual drug is different. So the Gonal-F is only follicular stimulating hormone, which means that it just contains one type of hormone to stimulate the follicles. Whereas the Pergoveris contains two hormones, so it's part follicular stimulating hormone and part is luteinized hormone, so LH activity, which is always very good to give. So it again, there is no enough evidence, I think, to say that which one works best. But there are some protocols that can be given to to people who had perhaps several, some failure or a low egg reserve, which implies having starting with a Gonal-F for the first week, and then from day 8 onwards, adding the Pergoveris, so switching to Pergoveris, so that you add that LH activity, which is that extra hormone that might just give the eggs that extra boost to get more competent and more mature. So this is called sequential protocol. So it's a combination of the two drugs, basically. But these are different drugs. So I wouldn't say that Pergoveris is better than Gonal. I would say that it is different and it can be used either as an alternative from the very beginning of the stimulation or in addition to the Gonal-F in the sequential protocol.
All right, again, thank
Okay.
you indeed for that. And I will go straight to the question that I see from Mary. Is it normal to have the last FSH injection more than 18 hours before trigger shot?
Yeah, sometimes we actually withdraw the FSH injections, so the stimulation drugs, even for more than 18 hours, even for 2 or 3 days. If there is a high risk of hyperstimulation, sometimes we do something called coasting. Coasting means, withdrawal of the FSH until the trigger is done, and normally is to allow the reduction of the hormone level to a safe level, so that the risk of hyperstimulation is reduced. However, I have to say that recently with the new protocols, with the antagonist protocol, we have the possibility of using a trigger shot, which is the agonist, and by giving that, we reduce the risk of hyperstimulation quite dramatically. So that's a rescue way. So it depends which protocol has been, in which protocol, has been used in this case. If it is a long protocol, then sometimes the FSH has to be stopped, because if it is too, the risk of hyperstimulation is too high, then that is the only option really to reduce the exposure to the estrogens. But yeah, sometimes we also don't give the stimulation as short. Yeah, so yeah, it depends. Then in that case, maybe the follicles were already quite big, and perhaps they didn't want to grow them too much. So that is when you don't take the FSH injection, and take obviously the Supracur, or the drugs to stop you from ovulating, and then have the trigger shot. I don't know if the reason was that the follicles were already too big, or if there was a risk of hyperstimulation, but that is usually the reason.
All right. Again, thank you for yet another question and follow up, of course, as well,
I follow
and
up, yeah.
your answer. And let's have a look, okay? Next question is from Angela. Do you have any knowledge of surrogates, even though the eggs are not hers, for her to turn on or trigger? Any genetic carrier conditions of donor or father imprinting syndrome? Anything you can advise?
Um, I don't really know if I understood the question. Sorry.
I'm afraid I just need the clarification as well, to be honest. So,
So
Angela,
the
can
eggs
you?
are not has to turn on or trigger any genetic, but the sperm is the one obviously from the commissioning couple, or is it the donor sperm? I'm not
Let's have a
sure.
look, of course. Okay. Let's see,
Sorry.
Angela, if you can clarify so we can understand it. But let's give it a second, okay? Because
Yeah.
I do believe that she is typing. So let's give it a minute. We definitely want to make sure that we understand it correctly. Okay, let's have a look. There is a follow up from Angela. So, husband sperm but donor eggs. I was told um, in Vitae who did genetic carrier screenings that a mother surrogate can switch on certain genes in the pregnancy. Okay, thank you so much, Angela, for
Thanks.
clarification.
I don't really know. Sorry, I'm not a genetist. I yeah I yeah I think this is probably a question for someone who does more like genetic studies.
Hmm. That's understandable, of course.
Yeah,
Thank you so much.
sorry.
So this is simply best to double check with Genesis then in such case,
Mm,
to get that um well advice, proper advice, I'm sure. So thank you so much still. And there is a comment from Angela. Okay, no problems, of course.
sorry.
It is perfectly fine, of course. All right. Next question from Mary. How long is best to wait between two cycles?
Right. So if the two cycles are fresh cycles, so you're gonna stimulate the ovaries again, then we usually recommend to have a couple of periods, to give the time to the body to reset a little bit, and then you can start again. If you had a fresh cycle and then you have some frozen embryos, then this can go back even the following month. And between two frozen cycles, there is no need to wait. Again, the frozen can be done one after the other. But think that cycles are quite intense, emotionally as well, not just for the woman, because the woman is the one who is going through the drugs, but also for the partner. So sometimes is better to have a bit of a break, but it is very much depending on how you feel really. But yeah, a couple of periods should be enough. Fresh cycle, yeah. Yeah, so two, three cycles, 2, 3 periods would be enough.
All right. Again, thank you so much for your question and, of course, for your help with that. And well, I need to take a look. There is a thank you, of course, from Mary.
You're
And
welcome.
I think that that was our final question. So thank you a lot for all of those questions. Definitely interesting ones.
Very
But
interesting.
also, but also, I want to mention that if you would like to have some, more details, or you would like to ask some more questions, there is also an option. As you know, you can get in touch with Dr. Arianna via her social medias, but also there is a link here I will send to you, and you can use it. There is an option to contact the Dr. Arianna as well. You can go ahead and do it. And well, Dr. Arianna, thank you so much for answering all the questions, for a very interesting presentation. And actually, there are some comments. So, of course, as always, I want you to see them.
Yeah,
They
thanks a
actually
lot.
were
Yeah.
sent straight after your presentation. I just left it
Mhm.
for the end. Precise and excellent presentation. Thanks. Very good and helpful presentation. And well, there are some more comments coming up. Thank you for informative and clearly explained presentation. Couldn't agree more here. But before I let you go, anything else you would like to add?
No, it's fine. It's been really a pleasure, actually. And I'm sorry if some of the questions were really too challenging, even for me. But yeah, as you said, I'm more than available. If you want to get in touch with me, social media works quite well, or through the email, not a problem. And I wish you all a very safe and a Merry Christmas. And many thanks for having me.
Thank you indeed. And well, it was a pleasure to have you. And thank you so much for your help with all of those questions. And as you can see, more of those thank yous are coming up, of course, for you. So thank you all for joining us tonight, for spending yet another evening with us. And I do believe it has been again helpful to you. So thank you, simply thank you for that. And Dr. Ariana, I do hope that we will have a chance to cooperate even more in the future. We will be finishing slowly with all the events this year, but as I've mentioned, we will definitely be back with some more of those. So I do hope that you will be able to be part of it as well. And as always, let me remind everyone that if you missed any part, or if you simply would like to rewatch it, you will be able to do it. It will be uploaded on our website tomorrow and on my IVFNS's YouTube channel. So if you subscribe, that way you will know when the video is uploaded. So go ahead and do it. And of course, as you know, we will be slowly finishing with those webinars. We will finish actually on Thursday. So I can only encourage you, and simply I hope to see you tomorrow at actually 5 p.m. UK time, because we have two events tomorrow. So I do hope you will be able to join us as well. Some more topics are coming up as well. And once again, Dr. Ariana, thank you so much for your expertise, for providing all those answers, and have a lovely evening or day wherever you are, everyone. Thank you so much. Take care.
Thanks, Caroline. Thanks for your help.
Thank you
Good.
so much.
Bye bye. Good
Bye.
night.